Right.
So thanks so much, folks, for coming. I'm gonna introduce our guest speaker for today. It is my pleasure to introduce Dr. Natasha Martin, who is a professor in the School of Medicine. Professor Martin and I have been working together for, I think, a few years now, working on HIV epidemiology, both in San Diego County as well as in Miami-Dade County. Yeah, thank you so much for joining us, Professor Martin, and I'll hand the floor to you.
Great. Thanks so much, Nima. It's wonderful to be here. Hi, everyone. Since we have a relatively small group, if I think it would be awesome to hear a little bit about you before I kind of launch into my talk. So if we could do a quick round of introductions, that could be great. So just maybe like your name, what types of things you're most excited about learning about in school, and then what you're most looking forward to this summer. So I'll start. I'll start. So my name is Natasha. I was always really, really interested in biology. I'm a mathematician. I have a PhD in math, but biology was always the thing that kind of what interested me most. And so I'll take you through a little bit of that, and it's really why I do what I do, which is merging kind of mathematics and infectious disease and biological systems. This summer, I am most looking forward to my friend is getting married in Bali. So I'm going to Bali for her wedding. She has 10 bridesmaids, of which I'm one of them. And she's given us each to wear one color of the rainbow. So I'm purple. I'm wearing my purple today. I guess that's my color. And I'm super excited about that. Sophia, do you mind going first?
Yeah, I'm Sophia. I'm a rising senior at Olympian High School, and something like yourself, I also really always liked biology, specifically genetics, and I'm really interested in biotechnology as well. So something that I'm excited for like next school year is I am taking a biotech course, and I'm also taking AP Chem, so I'm just really excited to like actually pursue my interest. And then this whole program is like my main like plan or like main activity of the summer, so I'm really enjoying it. And then also I have an orientation for another program that's like related to reproductive health. So yeah, like even though it's not like my intended field, like I'm just happy I get to explore my interests.
Amazing. Thanks, Sophia. So nice to meet you. Alaska.
Hi, so I'm Aleska. I'm gonna be a sophomore, and I think the subject that most interests me is probably math. Last year at school, I did take 8 classes, all of them which were like core subjects. But yeah, out of all of them, there was definitely math. And the thing I'm most excited for next school year or like this upcoming school year is probably continuing on my second year of my biomedical pathway, which is it's a really fun class. And this summer, yeah, I think this program is also like my main activity this summer. But I go back to school, I think next month, so it's pretty soon, not really
Oh,
much of a
so
long summer.
soon.
And yeah.
Amazing. Lovely to meet you. Harmony, are you able to join us and introduce yourself?
I'm Harmony, and I'm a rising senior at OTI, and my favorite subject is science, and I'm doing a AP Bio course next year, and this program really is my main thing this summer, and yeah.
Amazing. All right. Well, thanks, all. It's really wonderful to meet you. Also, nice to see so many women here. Um, I Yeah, I'll start. I have some slides, but I have a short video to start with that I think is actually much more clearer than I am in terms of describing what it is that I do. But let me kind of share my slides and start with telling you a little bit about me. Okay, hopefully you can see them. Oh, continue to share this PowerPoint. I know using SharePlay. What is SharePlay? I've never even heard of this. I'm going to continue. Okay. Okay, so as Nima mentioned, I'm a professor. I'm in the Division of Infectious Diseases and Global Public Health, which is kind of a cool thing because I mentioned I'm a mathematician, but I sit in a department of medicine, and actually my division is global health. And that's one of the things that I really like about it, that I kind of have this quantitative expertise, but I apply it to these real world public health problems. And so within this division, I'm really excited about being able to work with a variety of different, both, clinicians, epidemiologists, qualitative researchers, economists, and it really makes this really nice interdisciplinary environment that I work in. Um, and some of the work that I'll be talking about today, briefly, is the work that I did as part of the Return to Learn program, which was UC San Diego's COVID mitigation program. And as part of that, we used infectious disease and epidemic modeling. So I'll talk a little bit about that. And by the way, please feel free to interrupt me or ask questions or put them in the chat and we can talk about them afterwards. Okay, so a little bit about me. Because I think it's nice when you're at your stage to understand how people have very nonlinear trajectories, and that's okay. And that, in many ways, I think really helped me understand what it is that I love about what I do and put together the various pieces. So I mentioned, well, I'm from Chicago. This is the Bean in downtown Chicago, if you've ever been. And in high school, I was always really interested in biology. I was interested in health. I thought maybe I'd go to medical school and become a doctor. And I was always, but I did know that math classes were always the easiest for me. I liked them, I enjoyed them, but it was hard for me to kind of see the application of it. That sounds silly now because, of course, mathematics is involved in kind of everything we do, most things we do in our lives. But I don't know. I wanted to do research. It was hard for me to understand what mathematical research was. And yeah, I just was really always motivated by health problems and trying to think of ways that I could, use what I was learning to improve people's health and well-being. So I went to Stanford for my undergraduate. I was really happy to leave the freezing cold climate of Chicago and come out to California. And I started as a biology major, and I took a bunch of biology classes, and some of them I loved, and some of them I hated. Actually, it was more the chemistry aspect of the biology that I really didn't like. But in that process, I also continued taking math classes, and I stumbled upon a class where my professor merged the two, and she was a mathematical biologist. And what she did was she developed equations to kind of help us understand the biological processes around us. And in particular, was working on a project looking at leukemia and how we could best treat people that had this type of blood disease. And I was so interested in that because, yeah, I just thought it was really interesting. It was sort of something that I came kind of naturally to me, the mathematical side, but it was applied to a really concrete, health question. So I started working with her and doing a little bit of research during the summer, and I was hooked. I was like, this is definitely what I want to do. I really love this. This is so cool. And I learned about not just cancer modeling and other sort of mathematical biology, so modeling of biological systems. And that could be anything related to health, but it could also be related to, how bees swarm, how animals develop and from the sort of very early embryonic stage to create the patterns and organs that we see. And ultimately, I sort of focused on thinking about things like disease and health, but it was a huge, vast kind of field, and I thought it was so cool. So so I always kind of knew I wanted to do a PhD. Both of my parents are academics. I do come from an academic family. And so I always kind of thought maybe that's where I wanted to go. And so I ended up doing my PhD in the UK at the University of Oxford. And there I was working on cancer modeling. I was actually working on breast cancer modeling and tumor growth. And I was using these equations to describe how a tumor grows. And we were working with experimental models in mice to test out different treatments do imaging to see how the treatments were delivered to the mouse, whether it affected tumor growth. And I was using that experimental work to parameterize the models that I was developing about how the tumor was growing and how the drug could be delivered, and trying to think about how we might optimize that to prevent tumor growth. And so that was all very interesting, and I loved that. But at the end of it, I thought, maybe I still love what I'm doing, but maybe I want to do something a little bit different that has more of a public health, population health application. I really liked the cancer stuff, but I wanted to use the modeling to have more of a population health benefit, I guess is the best way to describe it. And so after I graduated with my PhD, I started working in a research lab that was working on infectious disease modeling and thinking about how can we build simulation models to help us understand infectious diseases, how they transmit in a population, and how they can how we can best prevent them and prevent their spread. So that I worked in the UK for 10 years in general. And then 10 years ago, I got recruited to UC San Diego, where I've been ever since. And yeah, and so that's what I do. And my particular research interests, which I won't talk about too much today, is actually around using modeling to improve the health of people who use drugs and other substance using and marginalized populations. I've done a lot of work in HIV and viral hepatitis prevention and drug policy, and then more work in other infectious diseases like COVID, which I will talk about today. And lastly, I'll just mention that, work is only one part of what we do. I'm also, I have a family. I have 2 kids. You can see here, my daughter Coletta is 10 and my son Sebastian is 9. And so, I think it's important to kind of show that you can be a mathematician, you can be a professor, also have a family, and that's complicated and a lot of things to balance, but it's certainly something that is important to me. Okay, so I have a very short, like 4-minute video to show you that really just gives the background to infectious disease modeling. So actually, before I go into that, just a quick raise your hand. How many of you have heard of infectious disease or epidemic modeling before? Okay, so you've kind of heard of it. Great. Okay, I think this video, which I'm going to try to share and may fail the first time, does a really nice job of giving a bit of an overview, which I will then talk more about. So let me share my screen with my sound and see if this works. Okay, I'm sorry. I'm gonna have to, in order to share my sound. So I'll be back in 1 second. Give me a second and I will be back. All right, sorry about that. You're right, Nima. We should have child the
No, it's all good. Murphy's Law.
Yeah, exactly. Okay, 1 more second. Let me bring this up again. Oh, and
Do you want me to share it for you? I could.
oh no, I'm there. I'm
Oh, you
there.
got it. Oh, perfect.
Okay, can everyone see this?
A model is a representation or simulation of something in the real world. Mathematical modeling is a research method that uses mathematics to create simplified descriptions of systems, behaviors, and processes. In public health, mathematical modeling is used to help answer difficult questions and understand complex relationships between biological, demographic, and environmental factors. Mathematical modeling cannot answer everything, but it can be very useful to understand certain types of public health problems and improve evidence-based decision-making with transparency. For example, modeling can help uncover drivers and dynamics of disease and mortality.
Natasha, I think the video might be
Okay.
frozen.
And
I don't know.
intervention outcomes.
Hold on.
And evaluate the
Sorry.
cost effectiveness of public health strategies. Every mathematical model begins.
Why is the screen frozen? Okay, I'm going to, Nima, give it to you, and maybe you
Perfect. Yeah,
can
I got you.
lead in this.
Let's see.
Yeah, this is why I don't usually share videos, but this one
No
is so
worries.
good.
Let's see. Okay, I have it pulled up. Let me, oops. Let me get the quality ready. And then now, share screen.
Thanks, Nina.
There we go, share sound. It's video sharing. Okay. So hopefully folks can see my screen.
Yep.
Awesome. But oops, I have YouTube muted. There we go.
Model is a representation or simulation of something in the real world. Mathematical modeling is a research method that uses mathematics to create simplified descriptions of systems, behaviors, and processes. In public health, mathematical modeling is used to help answer difficult questions and understand complex relationships between biological, demographic, and environmental factors. Mathematical modeling cannot answer everything, but it can be very useful to understand certain types of public health problems and improve evidence-based decision-making with transparency. For example, modeling can help uncover drivers and dynamics of disease and mortality, forecast future disease burden and intervention outcomes, and evaluate the cost-effectiveness of public health strategies. Every mathematical model begins with a question. Using tuberculosis prevention planning as an example, our research question could be, what are the potential effects of 3 interventions on TB incidence? 1. Purchasing a rapid diagnostic machine. 2. Conducting regular screening in schools. Or 3. Improving treatment success rates with incentives and enablers. TB is a complex disease, and its transmission is affected by many interrelated factors. But mathematical modeling can use what is most relevant to our question to untangle this complexity. An effective model of the world we are simulating requires gathering good information from sources like existing modeling studies, surveillance data, research papers, and expert opinion. A modeler will help us decide which specific method works best for our question. For example, dynamic or static, individual or compartmental, stochastic or deterministic, cohort or transmission. Next, to create a model diagram, we will need to use what is known about TB and how it spreads, as well as information on our interventions and local context. The model is then filled with the model parameters, the numerical data representing the essential elements of our simulations. When reliable information for a parameter does not exist, modelers must make assumptions based on the best available knowledge and expert opinion. The model is calibrated by fine-tuning the parameters and assumptions to ensure that it is an accurate and useful representation of reality that can reproduce observed and historical data. Modelers can then create other scenarios and simulate what would happen if certain conditions or assumptions change. In our example, we would be analyzing the potential outcomes of scenarios that match our 3 different interventions. It is important that modelers analyze the results for sensitivity and uncertainty. Always include a range of estimates for each scenario, and pay attention to any information limitations used to create the model. Finally, modelers and public health personnel interpret the model outcomes, draw conclusions, and make recommendations for action. For example, we might find that incomplete treatment is a major driver of TB transmission in a population, so in this case, intervention 3 would be an effective response. Public health decisions are based on many different considerations. Mathematical modeling is one research method to support systematic, evidence-driven, and transparent decision-making for complex public health problems. You can learn more about modeling for public health at the National Collaborating Center for Infectious Diseases, nccid.ca.
Okay, thanks so much, Dima. So that's really an excellent video. It sort of gives you an overview of the 12 weeks of my class that I teach in the fall. But I think it's sort of nice in introducing what it is that I do and how we do it a little bit, because I won't have time to go into all of the details. So, okay, are we back to my screen? Yeah?
Yep.
Okay.
Yeah, I see your screen.
Okay, so That was a good overview. So let's kind of start back at the beginning. What is modeling? All models are simplified representations of highly complex phenomenons, right? It's a simplification of a system. It could never possibly capture all of the complexity of the real world, but that's okay. What we're trying to do is create some kind of logical structure which attempts to mimic the real world in a simplified fashion to allow us to draw conclusions from that simplification. Now, sometimes models can be too simple to answer the question. They need to be more complex. And sometimes models can be too complex, overly complex, and we need a simpler model. So modeling is sort of this interesting tightrope walk of trying to develop something that is complex enough that it can kind of answer reliably the question that you're asking, but not overly complex that we're bogged down by the process of trying to develop and calibrate and get all the parameters for it. So I work on a specific type of modeling, which is called infectious disease or epidemic modeling. And within that, I actually work within a specific type of those models. And these models are called transmission models. So they simulate how an infection transmits within a population. So these are equations that these are models that are made up of equations that provide a mechanistic representation for how an epidemic is established over time. And the benefit of doing this is it allows us to project the epidemic through time and into the future under various conditions. So, for example, this is a model that one of my postdoctoral students, now faculty member Javier Cepeda, put together a few years ago. And he was trying to simulate HIV transmission among people who inject drugs in this area, Ekaterinburg in Russia. And so we put together a model, we developed these systems of equations to represent how HIV is transmitted through people who inject drugs. And as the speaker was talking about in the video I just showed you, we sort of tuned the parameters that we fed into the model to help us recreate the observed data. So here are these circles and these whiskers are our observed data points. So these are in this case, these were cross-sectional surveys of people who inject drugs, and then they would test for HIV. And here you can see that in 2001, about 35% of people who inject drugs were infected with HIV. But by about 2007, 60% of them were infected with HIV. So there was a very large kind of outbreak of HIV. And then it sort of stabilized at a very, very high prevalence, 60 to 65% of people who inject drugs living with HIV over the time period. So if you just focus on this sort of solid line here, this was the mean model fit across many, many, many model simulations. And these dashed lines are the uncertainty bounds. So you can see the mean model fit doesn't exactly fit this early trajectory. It fits the later sort of stabilization, but it gets the general trajectory right. And certainly within our uncertainty bounds across these many simulations, we're sort of capturing this early increase and then stabilization over through time. And then what these colored lines are projecting into the future. And we're saying, well, what would happen if we scaled up different types of interventions? How much would that reduce HIV prevalence? And we also looked at incidence and transmission in this population. And that's what these different colored lines are for. So it allows us to both predict what might happen if we continue doing what we're doing, but also what would happen if we kind of change what we're doing and increase some prevention intervention. All right, so why do we need this very complex engine? Why do we need these transmission models to simulate epidemics? You know, at the heart of it, it's because infectious diseases are infectious. And a lot of often what we're trying to do is simulate and estimate the number of new infections and how that will change over time. So, you know, imagine that we were meeting in person and I have, you know, the flu and I come to class and I'm lecturing and, you know, I'm sick one day and then I get somebody else sick. And so, you know, that day we have maybe one new infection. Then we come back tomorrow, we meet again, the two of us manage to infect two other people. So then tomorrow there would be kind of two new infections because each one of us will have infected one other person. And you can see that, you know, continuing if we were to come back again, where maybe the next day we had 6 new infections because this epidemic is spreading through the population. And this is sort of a characteristic, what we call exponential curve that sometimes occurs when there's an outbreak of an infection, especially one where it's a new infection and maybe there's no population level pre-existing immunity to that infection. So here is just one example of a sort of natural trajectory of an infection spreading through a population that would lead just naturally to changes in incidence or the number of new infections over time. But there are other things that can change this trajectory of how many infections we have over time. Demographic changes. So if, for example, on, you know, the second day, everyone saw that I was really ill the first day and decided, I think I won't come in person, maybe I'll attend class by Zoom, then obviously we could have, you know, fewer new infections. Or if everyone heard that I was just an amazing speaker and invited all their friends and we had 20 people come to lecture on the second day, of course that might affect how many people get infected that second day as well. Behavioral changes could obviously affect things. So if, you know, people decided to wear masks, or if I decided to wear masks, then that would affect the trajectory. Any other prevention interventions, if we had a treatment, for example, that could affect things. So essentially what I'm trying to say is there's a lot of different aspects that could change the trajectory of how this infection is transmitted through a population. And so we really need these dynamic models, these mechanistic models that have equations that underlie our, you know, our expectation of how the disease is transmitted and how these aspects of demography and behavior change and interventions affect that transmission in order to truly understand these dynamics. And so that is what I do. And at its heart, this sort of epidemic modeling is really a data synthesis. We need a lot of data to develop kind of accurate representations of these complex phenomenon. And so we need different types of data. We need epidemiological data. That might be, you know, an understanding of the prevalence of infection over time or the number of deaths over time to kind of inform and calibrate our model. We often use behavioral data. How much are people coming into contact? Who are they coming in contact with? Are they people of different ages? You know, you obviously come into contact with the contacts that you have at school are different than the contacts you'll have at home, or for your parents, the contacts they have at work. So all that kind of behavior affects transmission. The demography affects it, right? Some infections are transmitted differentially between children, adults, and elderly individuals. Some people are more likely to, for example, have greater morbidity or mortality if they are infected. You know, we know flu, for example, if you're infected with the flu, you're much more likely to have severe consequences or even die if you're elderly or very, very young. We need information about the biology of the disease, the natural history. So how long are people infected for? How long are they infectious for, right? What is their risk of mortality or developing severe disease? We need to kind of know those things. And we put all of that data and combine that with constructing a model that incorporates our knowledge about the biology of the disease, behaviors that drive transmission, and we feed that into the simulation. And with that simulation engine, we're able to develop outputs that are often hard to measure or in the future, right? So we're using this for maybe prediction. We often look at outputs like incidence, the number of new infections, hospitalizations, mortality, impact of interventions, etc. Okay, so that's what we do. Why do we do it? For infectious disease modeling, often what we're doing, why we do it, is to provide information to aid infectious disease policymaking or actions. That can be at the national level, that can be at the county public health level, that could be at the hospital or university level. So many different levels that we can inform decision making, but that's ultimately what we're trying to do. And there's actually a lot of different ways that we can use these models to help us understand and inform policymaking. One is to actually use the models to understand the drivers of transmission. Sometimes we might have observed epidemiological data in terms of the number of cases in different groups, but that may be insufficient to help us really understand what's driving transmission. We may have a relatively small group that comprises a relatively small fraction of the population, but because they're maybe highly connected, they are actually a critical driver in terms of the overall transmission. So this is actually one area of modeling that I think is less sort of well understood, that we can use it to kind of better understand the data we have. I would say forecasting is one of the most obvious applications of epidemic models and the ones that people tend to be most familiar with, especially since COVID-19. People are kind of familiar. They've seen forecasts of either hospitalizations, deaths, and that is, a very large way that these models are used. But forecasting is in a way, it's very narrow. It's trying to forecasting, the goal is to be very, very as accurate as possible. We want to predict exactly how many hospitalizations we might expect in the next 2 weeks, because we need to, allocate proper resources in our hospital or prepare for that. So accuracy when we're talking about forecasting is really important. There's another use for modeling, which I've already discussed with my HIV example, and that is more scenario-based projections. So here we're not forecasting exactly what will happen under each scenario in the next 2 weeks, how many hospitalizations. Usually these scenario projections tend to have a longer term window. We're looking longer out in the future, months, possibly even years into the future. We're compromising our ability to forecast accurately exactly what will happen in 2 years and 10 months from today. But what we're doing here is we're trying to understand in more broad strokes what is likely to be the relative benefit of doing intervention A versus B, or having policy A versus B, and to compare those two. And so those often drive more general decision-making about resource allocation. How should we think about allocating our resources over the next few years, for example? And finally, and this sort of overlaps, the resource allocation bit overlaps with the last application, which is economic impact. So these models are often not just used to say, well, if you scale up this intervention by 20%, you might have 5% fewer deaths. Policymakers often want to know both the impact, but also the economic or cost effectiveness of this. They want to know, how much is that going to cost them? And is that good value for money? And so we can layer the costs and the health outcomes on top of these transmission models I'll be talking about, epidemic models, to say, well, and then this is how much this program would cost you, and this is how much you might save. You might pay ahead of time in prevention intervention, but you might save it later on because you don't have to treat so many people who have severe disease. And so the economics tend to be a very important application. So just a few examples of this, some real world examples. So explaining the drivers of transmission. You could say, why are measles epidemics biannual in some places, but norovirus epidemics are annual, right? How can we understand something about the observed epidemiology? Forecasting or scenario-based modeling, I think, again, very, very common. Some examples are things like, what is the likely short-term future trajectory of the COVID-19 pandemic? That's forecasting, right? How many hospital beds, how many deaths do we expect to see in the next few weeks or months? More scenario-based modeling is something like, well, if there's a global flu pandemic, what should we do first? What would have the most impact? Should we close schools? Should we suspend air travel? Should we close our borders, right? These are very different actions. And often those are the things that the policymakers are trying to understand very early on. Well, where are we going to get the best impact right now? There's also much larger questions that are being asked at multiple scales. So for example, the question, what is the impact of climate change on malaria transmission, is a very important question. A lot of people are thinking about that. That's an interesting area where we have very complex models to simulate climate and long-term climate change. Those are models in and of themselves. They're forecasting the weather and climate change. And then they can be tied to models that simulate, where the vectors, where the mosquitoes for malaria live, how their habitats might change as we have these climates change, and then therefore where we might expect malaria to be present based on various complicated factors of where the vector is, where humans are, how they're interacting, etc. So that's an example where we actually have modeling of a lot of different things. Modeling of climate, modeling of these vectors, modeling of humans that get malaria, and we can tie them all together to try to understand and answer these really big picture questions. And then, of course, you might want to know about the impact and the cost effectiveness of interventions. So continuing our malaria example, what if we were going to mitigate malaria? What interventions should we prioritize? Who should we prioritize them to? When should we prioritize? What season? What area? What are the implications on how we most effectively and cost effectively intervene? If we only have a limited budget, how do we allocate it between, the different interventions we have? Bed nets, insecticides, malaria vaccines, etc. So, okay, so what does a model look like? I'm not going to take you through any equations today, but I'll talk a little bit about different model structures, because this is really how we think about it when I first sit down and develop a model. So one of the most basic model structures that you may have heard about is called the susceptible, infected, recovered, or SIR model. Here we often use schematics, and the boxes represent the different populations in our model. These are mutually exclusive. You can only be in one of these boxes at a time, but the whole population can be divided into people who are susceptible, people who are infectious, and people who are recovered and may be immune for this particular infection. If, for example, immunity and recovery is relevant in this infection. And the arrows represent how you can move between boxes. So people are either, let's say we're talking about an infection where everybody starts susceptible. There's no previous immunity. It's a new infection. People can get infected through coming into contact with infectious people and move into the infectious box. And then after a certain amount of time, they can recover and move into this recovered and permanent immunity box where they're no longer at risk of infection. So this is one schematic of a type of infection, and it would be accurate in terms of characterizing an infection that has recovery and permanent immunity, like measles, for example, or chickenpox. Now, obviously, there are many kinds of infections where immunity, for example, isn't permanent. You might have temporary immunity, in which case you would need a different model structure and maybe an arrow that moved from this recovery box back to the susceptible box. Or you may think of an infection, for example, like HIV, where there's no immunity. And so actually you just need this susceptible and maybe infectious, right? So we can think of a lot of different characterizations of these models, but this gives you an idea of, generally speaking, how we do this process. Okay, so now I wanted to take just a few minutes to talk about, well, how have we used something like this here in San Diego? And I want to talk about the Return to Learn program. So during the COVID-19 pandemic, we had a science-driven strategy to detect infection, intervene on it, and mitigate risk on the UC San Diego campus. And it involved a lot of different components of testing, environmental monitoring, and then contact tracing, case isolation, vaccination, et cetera, all these different things. But one of the key sort of underlying points of it is that it was data-driven and that it was adaptive. We continually collected data over time, and we changed our approach as the virus changed, as the environment changed. And we used modeling throughout the pandemic to help inform this. So one of the things we did very early on, so it was April 2020. So people, schools had just closed. Everybody, there was stay-at-home orders. Everyone was at home. And we were trying to think, okay, if we're able to bring students back on campus in the fall, how can we do this in a way that prevents really large outbreaks? And we were trying to figure out how to do that in the best way. And so the chancellor came to me and said, can you help us develop a modeling to help us understand this and what we might expect? So we developed a model of SARS-2 transmission, these boxes and arrows, like I just showed you. It's just as complicated as this, so a few more boxes, but not too complicated. And we used the model to try to understand, well, would asymptomatic testing help prevent these very large outbreaks? And if so, how much testing would we need? And so we ran a few different scenarios, and here what we are looking at is over time, if there was an infected individual introduced into a population, how many detectable infections would we expect to see over time? And when would we detect that outbreak with different levels of asymptomatic testing? So here, there's just one scenario of a sort of a larger outbreak that said that if we didn't have any asymptomatic testing, we just tested people who were symptomatic, we would detect the epidemic maybe on day 41 when there were 60-ish infections. That was quite a lot. If we tested the students at 25% per month, so basically once every 4 months, we could reduce that and detect the outbreak on day 33 when we had like 25 infections. As we increased our testing frequency, we could reduce the time to detection and the number of infections, clustered infections, before we detected it. And what we found essentially was that in order to achieve a greater than 90% probability of detecting an outbreak when there were less than 10 linked infections on campus, we would have to test more than 75% of the whole on-campus population per month. Okay, so we said, well, we are probably going to need an asymptomatic testing program. So the chancellor said, okay, we showed them the modeling. We showed them the modeling results, and he said, okay, let's set one up. So we set up a pilot, and we did a pilot of self-testing in May of 2020. And it showed that students could do it, they liked it, they could do it well. And so by the fall and then through the winter, we had this asymptomatic testing program. By December, we had 2 labs, we could do 12,000 tests a day, and we had these vending machines that were distributing COVID tests on campus. They could just take it from the vending machines, students could swab their noses, drop it in a box, and get their test results within the day. Okay, so then we kept doing modeling, and actually the county asked me, well, can you do some forecasting modeling? We want some hospitalizations and intensive care unit bed forecasting. And so we said, okay. And so all these dots are the sort of data points, and the lines are the model trajectories with the uncertainty bounds around it. And you can see we kind of calibrated to the model to the observed data, and then we were able to forecast out hospitalizations and intensive care beds and we did this. And we did this both for the county to help them understand what was going on. We sent this to the health system to help them understand how they should allocate beds and personnel in the hospital. And we fed this into our campus modeling as well. And then we developed this really interesting type of model called a network agent-based model. And I'll explain it in a moment. But it was a model that we needed to develop to answer some really fundamental questions about how to bring students back in the fall. And so some questions that we got were things like, well, if we have residential students on campus, should we house them in doubles or singles housing? Should we have limits in terms of the maximum class sizes, or should we have a sort of hybrid instructional policy? What impact would an important fraction of students coming at the start of term with infection from home, because we knew some of them might come infected, what impact could that have on transmission on campus? What impact could persistent seeding of infections from the community have on what we see in campus? Because students obviously don't just stay in their dorm rooms. They go out and they go to grocery shopping, they go to the community, right? So how much could that affect what we see on campus? What could be the impact of isolation, contact tracing, quarantine, masking, social distancing, and again, asymptomatic testing frequency among residential students or those coming on campus? So we had all these questions. These were the questions that were asked to us, and we had to think, okay, how can we develop a sort of modeling framework to answer some of these questions? And so what we did was we developed a model of SARS-CoV-2 transmission in natural history. And here again are sort of boxes and stages of how people move through the different stages in the model. And we simulated a population. And here what was different about this type of model was that it was called an agent-based model, which means each individual is an agent. And we actually simulate each individual explicitly that comes onto campus. So in the fall of 2020, we had about 46,000 individuals we expected to be coming onto campus. That's about half of what we usually have. 15,000 undergrads that were residing in campus housing, 15,000 undergrads not residing, living off campus, about 8,000 graduate students, about 8,000 faculty and staff who are working on campus. So we simulate each of those different populations. And we put them onto these networks. And we had to do this because some of the questions that they were asking were related to things like class sizes or roommates and suites. And so we needed to actually be able to simulate these different environments and how people were contacting each other in these different environments. So here, the circles here are now actual individual students. So we have a student here in red who maybe shares, is in a double with another roommate. And that room may have multiple bedrooms sharing a common kitchen and bathroom area in a suite, right? So they may have other people that are their suite mates, and then other individuals that they come into contact with that just live in their building. But obviously they're in more contact with their roommate, less contact with people in their building. And then this student may also then would have different classes. These classes have different class sizes. Some of them are larger, some of them are smaller. And those are all fixed. Those networks are fixed. They don't change. You have your classes, they're set. People you see in your classes are the same. You have your roommates, they're set, more or less. But then we also have these just sort of random campus connections, just bumping into people as you walk across campus, go for lunch, etc. And that is a sort of random network of people meeting and mixing a day. And of course, we also had off-campus students that we had to simulate that were also coming to classes, also coming and hanging around campus, etc. So we built a simulation model, and then we wanted to look at things like, well, what is the likely average outbreak size we can expect with these different kind of policy interventions? And so here on the left-hand side, what I'm showing you is simulations that look at the average outbreak size over the course of a term if we had doubles in in-person instruction, let's say about 60. But if we had doubles in hybrid instruction with, oh no, and I can't read the bottom of this slide because my slide controls are blocking, but hopefully you can read that. You could see that it reduced that. If we had singles, then that would reduce it even more, right? And if we had singles and hybrid instruction and masking and social distancing, then it really reduced it a lot. Then we were trying to get below 10 here. We didn't want outbreaks larger than 10. And that really could only happen if we had singles, hybrid instruction, and masking and social distancing. So that helps us inform. And in fact, this helped inform basically the decisions in terms of how students were brought back onto campus. And this is just another visualization from that model. You can kind of look at it. We had a dashboard that students or anyone could kind of play around with different scenarios and assumptions. And, these little dots are now the outbreak sizes. If there was an introduced infection over the course of a term, you can see most outbreaks were very, very small. Some outbreaks were larger, predicted to be larger. And we kind of could look at this with different scenarios. The largest outbreak was associated, we saw on the modeling, with the largest residence. So we really tailored this model to the exact data on campus. We had all the different residences. Some of them were small, some of them are large. We simulated that down to the room level. We simulated all the different classroom sizes, large to small. And what we found was that over the course of many model simulations, the largest outbreaks that we saw were really associated with the largest residences. So we thought, how can we mitigate that potential risk? We can't change the sizes of our buildings. But what we could do was start a wastewater monitoring program. And so we started this very ambitious residential wastewater monitoring program where we collected wastewater every day from 128 samplers across campus. Which collected wastewater from over 340 buildings, both residential and non-residential. And we had really nice maps, sewer maps, to know how all the buildings connected to these sewers and how they all kind of fed into each other downstream. And what we were able to do is with these daily samples that were collected and tested, we were able to oh, here we go. Sorry. We were able to develop these beautiful maps that were online. Everyone could see them, and it would show us which buildings were positive, which buildings were negative, which buildings weren't sampled that day across campus. And what we were able to do is just say, well, there was a positive wastewater signal in these buildings. Please go get tested. Please get a test. And it helped us identify early whether there were potential signals indicating that there was a brewing infection or outbreak. And actually what we found was this wastewater testing was so incredibly sensitive. It could detect a single asymptomatic individual in a building. And so we were able to action very early on and alert students living in those buildings that they should get tested to prevent very large outbreaks happening in those larger residential settings. All right, so that's about all I wanted to talk about today. I hope I've given you an overview of what epidemic modeling is and shown you that it can be a very useful tool for improving our public health response to infectious diseases. And I'll just end by saying that we're in, a very difficult time for public health. There's likely very dwindling funding for our public health agencies. And so there's even more pressure to ensure that what they're doing are the most impactful and that they're using their resources as wisely as possible. And so that is really what modeling can help us understand and provide data to inform decision making to ultimately have the most impactful public health response. And with that, I'll stop sharing my screen, and we have about 5 or so minutes if you guys have any questions or comments about it.
You mentioned that you did your PhD at the University of Oxford in the UK, and I was just wondering, where did you do your undergrad?
So I did my undergraduate at Stanford. I was at Stanford in California, and I will say that I actually started my PhD in Vancouver in British Columbia in Canada. And I just wasn't happy there for various reasons. I was with a mentor who was amazing, but it turned out that kind of what we were interested in really wasn't aligned. And so I dropped out. And I dropped out and I thought, I still want to do this graduate school thing, but that just wasn't the right place for me. And I ultimately ended up in the UK at Oxford. And I say that because when you look back, it all sounds very, Stanford, Oxford, professor, but actually it really wasn't that way. And, again, I started out in biology. I liked it. That wasn't quite right for me. I ended up in mathematical biology. I started out in one graduate program, wasn't quite the right fit, ended up in another. And I suppose one thing that I learned is, don't be afraid to kind of follow your heart. And that can take you in unexpected directions, but I think is the best way to end up to kind of land in the place that you really love. And it did take me a while. Even with my PhD, I was doing cancer modeling. Good fit, not the perfect fit for me. Then I ended up in epidemic modeling. So I kind of, throughout my whole career, have kind of made small adjustments and changes over time. And I think I've eventually landed exactly where I want to be, but it certainly wasn't where I thought I'd be when I started, right? And so, but listen to that inner voice that kind of might tell you that you might need to adjust your path slightly.
And then since you did your undergrad and your PhD like in two different regions, what do you think, like, were you able to pick up on any stark differences between the education in the US versus the UK, and which do you feel like you enjoyed more?
Great question. So I will say that I think that the system is slightly different in the UK. PhDs are purely research based. There's no taught component. So, and that means they're shorter. So in the US, you might take, let's say, 6 years, 5, 6, 7 years plus in a PhD. At least 2 years of that might be just solid coursework. And then you have your 3, 4 years of research. In the UK, it's just research based. So in that sense, more people do a master's degree first, whereas in the US, you can just go straight to PhD if you want. There's a lot of good reasons to do that. If you know you want to do a PhD, you don't have to pay for the master's, la-di-da, but obviously you have to be sure you want to commit to that length of time. So that's a big difference. And because I didn't do a master's degree, it meant that I didn't have that, didactic coursework, and I had to kind of do that on the side, pick that up on the side. So I think that's a big difference. But in general, I think that they're similar. I think there's more variation between programs, is my feeling about it. So there are some, and advisors. There's some advisors that will be very hands-on, hands-on mentors, really working with you, wanting to see you a lot, really holding your hand through that process, and other mentors who are very hands-off and let you do that. And honestly, a lot of it is who you are as a researcher, what matches your style. I think there are benefits to both. Too hands off is bad because you don't get enough guidance. Too hands on doesn't train you how to be an independent researcher and doesn't give you the space to grow and think and explore in your areas. So there's no right or wrong, but it's definitely there can be a mismatch. And to that, earlier about my original kind of mentor mismatch, you kind of figure that out as you go. But doing research early on, if you can, getting involved in it as an undergrad will help you understand a little bit. If you do end up wanting to go to graduate school, will help you understand a little bit kind of your style, the styles of people you like working with to kind of give you a better sense of that.
Okay, thank you. And then for my final question, I thought the Return to Learn program was really notable, but what's the project that like you've conducted or like you've contributed to that you're most proud of personally?
That's a great question. So my biggest piece of research and what I'm known for is the work that I've done in hepatitis C elimination. So hepatitis C is an infectious disease. It causes liver disease and mortality. It's one of the leading causes of mortality. Liver disease is one of the leading causes of mortality worldwide. So it's a big problem. And it's an interesting area because we have these revolutionary new treatments, which is new and everyone's very excited about, that are curative. But it also tends to affect a population that's highly stigmatized. It tends to be transmitted through people who inject drugs, who often have a very hard time accessing care. They experience a lot of stigma. They have a lot going on, high experience, homelessness, etc. So what I'm interested in and why I love this area is that it sort of is it's modeling, but it's talking about social problems, talking about things like drug use, drug policy, right? That kind of intersects with a lot of interesting social aspects that I find really contextualize the modeling in a way that I think is really important, and that has been a big passion for me.
Okay, thank you so much. Also, I just wanted to thank you for taking the time out of your day to provide this lecture. It was really interesting. I was taking notes and it's very, very enlightening.
Thanks, Sophia. It's so kind. And thanks, Nima. I'm assuming you put a paper in the chat of mine.
Yeah, I Googled your name and hepatitis C, so I think that sounds like the paper you're talking about.
Yeah, that's me. Awesome.
Natasha,
Well, I
thank you.
know we're at time, but please feel free to reach out if you have any questions about either modeling or just academia or math or biology. Love to chat. I've been working with Nima for many years, and he's absolutely fantastic. And Nima, I'm sorry I didn't talk about what we do, but
No,
very
no, this is better because Joel talked about the virus like sequencing stuff already, and even in your return to learn part. So the wastewater samples that Smruthy and those folks collected then went through my sequencing pipeline. So they're getting some exposure to it separately. So
awesome.
this is perfect.
Very good. Okay, super. So thanks a lot. Have a wonderful summer all. Good luck with your careers, and feel free to reach out if you
Thank
have any questions.
you.
Thanks
Thanks so much,
all.
folks. Thanks,
Okay.
Natasha. It was great having you.
Thank
Bye.
you.
Bye, everybody.